Presenting on behalf of Medicine 5, Misleader. Mr. X is a 24-year-old gentleman. Previously, he's working in a battery manufacturing company from West Bengal. He presented with complaints of recurrent abdominal pain for the past 5 years, once in every 3 to 6 months, and joint pains involving a knee without swelling or tenderness for the past 6 months. Historically, he's apparently well till 5 years ago when he dealt with multiple episodes of severe abdominal pain, epigastric region, colicky type, with associated nausea, and he also had difficulty in passing through with every episode of pain, and each episode of pain lasted for about 5 to 10 days. Then he stays well for another 3 to 6 months, after which the abdominal pain recurs. Till now, in the last 5 years, so far had more than 10 admissions, every time requiring IV analgesic for pain relief and enema. No history of abdominal distension, jaundice, or blood in stools. No history of seizures or memory disturbances, urinary complaint, loss of weight, photosensitivity. Prior known comorbidities, he's working in this factory for the past 6 years. Before, he was used to making gold ornaments in Rajasthan. His 2 brothers, no other illnesses in the family. On examination, he was conscious, he was over in time, place, in person. Pulse rate was 54, it was regular. All pulses were palpable. Blood pressure was handled by 60. There was pallor, no extras of clubbing or lymphadenopathy or peel edema. Oral cavity had poor oral hygiene. Thyroid, skin was normal, nails were normal. Respiratory system, cardiovascular, abdomen system was normal. Nervous system did not show any neurological deficits. No wrist drop, no finger drop, or a foot drop. So, what are the it's a young factory worker with no known comorbidities or family history, with complaints of recurrent abdominal pain, polyarthralgia, constipation, and anemia. What are the differentials we consider? So, this recurrent abdominal pain in the absence of tenderness or an organomegaly or a mass or an identifiable local inflammation there. So, the anatomically, we're considering whether the stomach or the vasculature, the bowel or the renal or biliary trees, and the cardiac or esophagus and the rare causes. And pathology wise, is the toxic because of factory worker, and metabolic reasons, inflammatory, obstructive. The etiology wise,
you said it's a colic here.
Yes, sir.
Why are you saying vasculature there?
So chronic. So because it's, the colicky part of it is it's against it, but because episodic pain, which rarer can. It was colicky pain, so once in every. Oh. The differentials we consider for a colicky pain was a biliary or ureteric colic, lead poisoning, intermittent porphyria, DKA, inflammatory bowel diseases, or irritable bowel syndrome. So, as in investigations, hemoglobin was 7.2, anemic. Yes. At the nutritional. His hemoglobin was 7.2 with an MCA of 91, normal cytic, but the REW was increased. His reticulocyte production index was low. Blood picture was shown, and isocytosis, poikilocytosis. Platelet count were normal, 150,000. Total counts were normal, 7,000 with normal differentials. LFTs were normal. Urea creat electrolytes were normal. Evidence of inflammatory markers, ESR, CRP cutoff was 6. It's just above 8. 6. The value of 8. Urinary did not show any proteinuria or any other evidence of renal abnormality. His anemia workup, his iron was 86 at the TIBC 190, transferrin saturation 41%. B12 was 295, folate is 3.4, which is 3.4 is lower than the cutoff limit. His 24-hour delta ALA was 32.8 milligrams, the normal range is 1 to 7 milligrams. So next we done a CECW, which is normal. Because of the complaints of joint pains, we've done an X-ray, look like any local pathology is there. The knee joint space are preserved, bone looks normal. Soft tissue, there were no soft tissue swellings. So further, we went into the heavy metal screening for this guy. His lead levels in the blood was 73 points, so supposed to be less than 10. The joint pain, the uric acid was 6.9, which is less than, for a male, it's in the normal limits. EMG and did not show any evidence of neuropathy, motor evidence. So I'll be presenting just an update on the lead poisoning. So the various pathology-wise, how lead affects in the systems were it inhibits the antioxidant enzymes like glutathione, superoxide dismutase, increases the reactive oxygen species. This can cause mitochondrial injury and cell membrane damage. It also binds to enzymes to sulfhydryl groups. which makes them inactivated. And it competes with the other divalent ions like calcium, magnesium, and there is a role in carcinogenesis also. So it inhibits, it causes anemia by multiple levels, multifactorial. It decreases heme synthesis by delta LA dehydratase and ferrochelatase enzymes. The 5' nucleotide is involved in degrading the nucleotides from RNA from the RBCs, but in the absence of the enzymes, those will accumulate in the RBCs, which cause basophilic sibling. Then it also, with the renal dysfunction, it also decreases the erythropoietin levels. In a central nervous system, it competes with calcium and can cause because calcium is involved with the exocytosis and the movement of the neurotransmitters. It impedes that. It impairs the myelin and causes destruction of the astrocytes, finally resulting in encephalopathy, dementia, even impaired IQ lowering in children. Peripheral nervous system, predominantly a pure motor neuropathy, either by injury to span or demyelination and resulting in axonal injury. Kidney or the proximal tubular injury can be there, which resulting in aminoaciduria, glycosuria, and phosphaturia. A chronic lead nephropathy where there's continuous damage causing interstitial fibrosis and irreversible changes. Endocrinopathies involving thyroid, adrenal, and pituitary dysfunction. Cardiac, most common is hypertension, and secondary is bradycardia. GI, it can cause colic, and constipation, probably secondary to a motor dysfunction. Musculoskeletal, there can be seen lead lines in the X-rays in the long bones, and the vertical lines are seen on the gums at the junction of the teeth and the gingiva. Reproductive system, it can decrease the sperm function and also impair the hypothalamus pituitary testosterone axis. When the lead affects children and adults differently, probably because the bone composition and also the blood-brain barrier status. And so the picture on the left side is our patient where the gingiva and the teeth, there is no line there, where the classical Burton line is described in this other picture where the blue color, it's not clearly visible here, but here it's the faint blue line here at the edges. It's because of the lead interaction with the bacterial sulfide groups causing that. How do we assess the severity based for a patient? So he's come with abdominal colic and he had anemia. So this falls under a severe category of a lead poisoning, and his levels were in the 73.5. So the other symptoms which based on it we can classify as into mild, moderate, severe is a severe form. So how should we treat it? The primary mode of treatment is by source identification, whether it's internally with the abdomen in some lead being released from internal structures, or whether it's from acquired through outside sources, other work or other places. And secondary thing is to go out with the chelation, and finally the symptom control for the pain and seizures and depending upon the organ involvement. So the source control is predominantly from where he's acquiring it. Either from, previously it used to be commonly the lead pipes, where the plumber and the plumbum taken over the words. And it's a workplace. He does this smelting for the battery manufacturing in the lead. So this is just the examples of the internal causes which somebody should also be considered when considering a lead poisoning. There's a child picture where he swallowed one lead pellet from his father's gun some time back, and this is a shotgun injury with multiple lead deposits inside. And this is another child with pica eating the paint chips. And this is after bowel irrigation, it's completely come out. So why should we treat lead poisoning? Because the lead stays in the body for a very long time. In the bone, it even stays for almost 10 to 20 years. Whereas the blood levels can stay up to 25 days in adults, and in the children, it can stay up to 10 months also. So the soft tissue on the bone component, it's continuously there's a redistribution from bone to the soft tissues and to the blood and the urine. So when should we treat it? So the two reasons should we consider the symptoms and the peripheral blood levels. So if they're symptomatic or if the blood levels are more than 70, they should be treated. So the agents of choices are, there are 4 agents so far available. The dimercaprol, it's a British anti-leukocyte. It's given at a 4 mg per kg dose and predominantly hepatic excretion. The calcium disodium EDTA, it's another, it mobilizes from the bone and it is excreted renally. But there's a risk of encephalopathy because it is mobilizing from the bone and bringing it to the peripheral blood, from where it can go into the brain again. The Saxenda is the oral drug, which is a derivative of dimercaprol, which can be safe. It's much more safer compared to dimercaprol, and it is more. It's also a soft tissue mobilizer, and it's safer in. It's more safer. Yeah. It also excreted renally. D-penicillamine, it's not advisable because of the safety spectrum, but it can also be used when the others are contraindicated or they are not tolerating the other drugs. So specific to each drug, the ball is an oily preparation, so it has to be given a deep IM injection. So it's very painful for the person, and also other things to consider: do not give iron supplementation that time; it can cause, and G6P deficiency can cause hemolysis. And because it's excreted to the liver, liver dysfunction is contraindicated. Calcium disodium EDTA, when you're giving it, it mobilizes from the soft tissue. Since you should give it after the ball, because once it comes to the blood, it can go back into the brain and further is encephalopathy. So preferentially, you should first give the ball. 4 hours later, anyway, the ball will come into Q4H hourly. So that time, the calcium EDTA should also go. So because a chelating agent also chelates zinc, so zinc supplementation should go on along with whenever there's on calcium disodium EDTA, and it can precipitate an acute tubular necrosis. So that's why maintain a target urine output of at least 1 mg per kg. So the other Saxenda, which is the most safest and preferred option right now, it's not there in CMC, but it is specifically affiliated to lead and lesser chances of other complications. Penicillamine, it's not at all approved for therapy, but yeah, because of completely a lot of multi-system involvement causing severe disturbances. So what is the endpoint? When do we stop treating him? So what are the current recommendations? Says that recommendation should be when should we treat is based on either the clinical symptoms, blood levels, and the drug which can give based on the side effects of the treatment. So at presentation, in case he had encephalopathy or any severe symptoms. Severe symptoms are based on whether they had the colicky pain or the anemia or the neuropathy or the blood concentrations at presentation was more than 100. They should get repeat course of treatment. So you can wait for 2 days. And what can you give after? We will send the lead levels again. So based on the lead levels, one of the 3 agents preferably. Rarely, a third chelation also may be required depending upon the lead levels. When patients is asymptomatic, their lead levels are less than 70, you can even wait up to 10 to 14 days to further allow the lead to re-equilibrate from the bone into the soft tissue to the blood. So does this chelation works? So why are we so keen on chelation? Because but whatever studies so far, we do not have any evidence to say it actually reduces the total, because the blood levels is what we're able to measure. We don't know what is the lead level in the soft tissues and the bones. So so far, whatever we could identify, it only reduces about the metal from the body by only 1 to 2%. And there's no evidence so far to suggest that it actually penetrates the soft tissue such as brain. So this is for our patient is a factory worker. The permissible limit from Indian Labour Organization and also Tamil Nadu, it's about 15 micrograms per deciliter. For him, it's about 73. So he should not work anymore. So if it's less than 15, is it okay? But other studies have shown already that even at lower levels, even 5 micrograms per deciliter have shown a drop in IQ in children. So any lead level is not health. Yeah. So and lead poisoning is very common. Like it's more than what we consider actually. So it's globally wise in 2012. They were able to identify that 275 million in India, which is almost 50% of all the children. That's 1 in 2 have blood levels of lead, which is more than 5%. And the impact of it can cost a lot of billions of dollars. So in India, where Tamil Nadu stands at the level of average is 6.23, which is still above the 5 cutoff. So the risk of this thing. And in Vellore, do we have lead effect here? Previously, there were a lot of this tanneries where the lead was, so most of the workers previously had. Right now, it's more safer. But in this last 2014, there's one place, preschool children, where previously there was a smelting factory was there. They were identified, they followed other children, they had lead causing poisoning symptoms in the children. So what happened to our patient? Our patient, we given him both a combination of bile and calcium disodium EDTA. Because we didn't want to cause further worsening. He didn't have an encephalopathy at presentation, but we did not want to cause further worsening of anything new onset. And also, even it causes a faster rate of drop in lead levels, even though the blood lead levels may be same at the end of either giving individually. So the response for our patient, we assessed the lead levels on day 3 and day 5. Day 3 lead levels were 21, come down from 72, and day 5 lead levels were 13. However, post discharge on review OPD, his lead levels have come up again to 51. So the redistribution yet. We did not do a baseline urine lead for him, but however, a 24-hour urine lead on day 3, which shows a 7,900, which is mobilized from the body and being excreted in the urine. The delta ALA in the 24-hour urine at day 5 was 1.8. Previously, it was 32. Suggests that the heme synthesis is back in action. And the hemoglobin previously at presentation was 7.2. Post chelation was 7.4. And almost 3 to 4 days, it became 9.6. But at the same time, we supplemented this folate also after completing, because he had a combined folate deficiency. So yeah, zinc levels, we sent it, but the lab was not following it. So we kept him on prophylactic anyway. So our patient he had abdominal colic and this hematological anemia, which is a combined from folate and also a lead poisoning, and it was a rapid improvement. We were considering whether should we label it as severe at presentation itself, or we should consider it as a moderate and follow up with the second lead level, which is 51, and leave him, which is make a plan. So yeah. So during the 5 days of chelation, he got his renal function remained stable. There was no dyslipidemia. His liver enzymes and bilirubins were stable. This AST alone just went up mildly because of the deep IM injections he was receiving the valve, which caused severe pain and muscle injury a little bit. So the AST has gone up. The taking points: the work exposure limitation is the main stay of treatment for lead. The blood lead levels does not mean the whole body burden. And in adults, consider chelation only if they're symptomatic, or plus or minus if the blood lead levels are more than 70. And consider the side effect of the profile of all the agents which are available to use at that point of time. If the child is acting out, please do consider lead levels. It's very common. 1 and 2 children. Thank you.
We have exceeded 20 minutes. Have any questions?
Wasn't the diagnosis made if it's okay with given the occupation with significance and that?
Yes, sir.
So he came with that.
He came.
Why did he come first after that?
Diagnosis was not made in his occupation place. He had come to gastro for the abdominal pain. They had made the diagnosis and referred to medicine.
So the mandatory occupational safety clinical also.
Yeah, he apparently they evaluated, but every time they just treat typical symptom. And he never got treated in 5 years. So.
We should get back to the employer. Compensation.
Yes.
Today's prize goes to Tony.